the future vascular surgeons UK experience?
Thank you very much for the introduction and the kind invitation. It's a pleasure to be here and opportunity to be with all of colleagues in this very nice event. So I'm going to talk today about training future vascular surgeon. And I have a couple of disclosures before I start that they're not real financial disclosures, but I trained between Egypt and the UK. And I think it has been a very enlightening experience to be trained in two different healthcare systems, and I highly recommend it, but I can't see many trainees in the room. The second thing is I've been the education and training lead for Guy's and St. Thomas's for probably a few years now. However, a big part of my talk today is going to be mainly focused on personal opinion rather than representing exactly the UK system. So as we heard earlier from my colleague, that we have moved from an apprenticeship era into a simulation, AI, and virtual reality in training. And this has been happening in front of the eyes of many of the senior surgeons in the rooms. And I think there has been a genuine struggle to really move the way we are training future surgeons, because we have trained in such a way and we are so convinced that it is probably the best way. Slowly moving into why changing the way we train future vascular surgeons is challenging. Well, first of all, the educational dilemma is a very important one. We are training surgeons who are going to be consultants in the future and in the far future, but we don't know exactly how is that going to look like. So you are training people to a future that you don't necessarily know whether the technology is going to change and how is that going to take it. The fast pace and the change of technology is making it very difficult to put all of the training needs in a certain period of time that lasts you for all of your career. So clearly, there will be more than one time during a 30 years career for you to learn new things. Of course, the overlapping specialties with IR, cardiology, and vascular heavily involved, treating pretty much overlapping diseases and using similar techniques doesn't make things easier. The healthcare budget has always been an issue, but now more under scrutiny from administration and putting a lot of pressure. And then the training versus service delivery tension. You can always do a little bit more if you don't train. You can finish cases faster. You can probably do a slightly higher quality in certain cases, but we need to train to invest in the future. And last but not least, the work-life balance and all of the impact on the well-being that we've been talking about. So the education and training dilemma, this is from the primary schooling literature, and it is saying that curriculum has to change, because when it was designed for primary schools, it was designed for a certain time where the needs and the important subjects were there for a reason in the industrial revolution, but now we have moved into a more of an information age society, and maybe primary schooling has to change. I find a lot of relevance of this to training program in surgery, because we have moved significantly from where we are. And should we really relook into the curriculum and what are we teaching and what are we training? In the UK, and putting a little bit of focus on that, there has been the biggest impact was expanding curriculum and shrinking time. We were hit, as all of the European, with the European Working Hour Directorate, by the 48 working hour week, and I don't think surgical training was ready and prepared for that. And then you had to squeeze all of the training into this, maintaining a good quality. We've added management, teaching, research as prerequisites and a list of long courses. And the only compromise we had to make at that point is to prolong the training. So these are the net outcomes: less training hours per week, less continuity because you don't stay overnight and over with the goods and the bads of this, and less overall experience for longitudinal experience, so you don't see the patient all the way through all the time. And then a longer training period spread on 10, 12, or sometimes 14 years with the research. Some upsides is a chance of subspecialty and rotation between one specialty to the other, potentially a better quality of life for the trainee. Now, going back to an effective training program, well, I mean, this is partially from the literature, partly my view. The training program need to select those who are appropriate for that particular training, and then
enable the average trainee. It has to be designed for the average trainee to become competent, and it has to allow the outstanding trainee to fly, to really be exceptional and achieve excellence, not hold them back. And finally, to support and mentor and sometimes redirect those who are struggling, who actually came to the wrong training or the life circumstances has put them in the wrong training. So I think this is very important to realize in any design for a training program. And these are one way of looking into the content. You have got knowledge, skills, and everything else I would put under professionalism, the behaviors, attitude, and some of the soft skills. Now, what can we do with them? Well, we need to have a look onto what have we added. And this is just a very quick one. We've added on the knowledge, in addition to the expanding vascular knowledge, we've added a little bit about management and healthcare systems. We've added biotech. We've added a little bit about innovation, R&D, simulation. But have we taken anything out? Have we actually designed it to take anything out? I think we need to take some stuff from the curriculum out that is not necessarily used, maybe less knowledge about the general surgery, maybe less knowledge about the parasitology if it's not needed in certain areas, and then how to make it easier access by the different kind of modalities to achieve that. Now on any electronic with the webinars, and there is access to knowledge that is much easier. Who should train? We shouldn't be fixated that it has to be the senior trainer. It can be non-medics. It can be multiple resources. And now I'm going to go to some of the skills which Sharif Al-Lawzi just touched on quite nicely. I do not think that there is a huge mutation, genetic mutation, that made the playing at this era completely different than this one. What happened is the technology, the advancements, and the way they train. And there has been huge amount of evidence for simulation training and its value that has been in front of our eyes since the 50s, but we were so resistant as a medical community to really put it as part of the curriculum. I think now we have got much better, and I deliberately got the literature from far away and not necessarily medical. Now we are better. Are we good enough? I don't think so. This is one Insitu simulation that we ran at Guy's and St. Thomas's. We do have a simulation center. I put my hand up that I'm guilty of not using it enough for my trainees, but we do some in-situ simulation. This is simulating a ruptured aneurysm, and I think this is a valid one. You can go to low fidelity simulation. You can go to a very simple jig, and I think everyone in the room should start to think how to incorporate it in their training. Now, there are few concepts and skills that we need to teach the juniors. I try from medical school now, which is learning to learn. So teaching them skills of how they can learn better from every opportunity. We need to be able to articulate that and help, because they will need to learn as they carry on through their career multiple times. Reflection and how they reflect on their practice, and a little bit about the team and the co-leadership. The one-man show has gone, well gone, and being able to operate and being able to be in a co-leadership role with a colleague side by side, both of you are leaders on the same level, is something that we need to teach them instead of creating and generating conflicts with that. Just have one last one to conclude with it. This is basically what I would recommend that you would look at if you are redesigning your training program. The curriculum, training, and trainer are the training program components. There are variable regional and local factors from outside that impact that and have to be put in consideration. There need to be entry, there need to be assessment and progress, and there need to be an exit point. And finally, these are my thoughts to share. Consider redesigning rather than patching and adjusting the training program. Curriculum need to be reevaluated both from content and how is it re-delivered. There are always and will always be finite resources, time, money, so manage the energy of the trainee well, more use of simulation, and alternative training tools. Thank you.
Thank you very much.